Hello, I'm Dr. William. Today we will discuss current guidelines for the treatment of atrial fibrillation. Atrial fibrillation, AF, is one of the most common heart rhythm disorders. The following types of atrial fibrillation are distinguished. Newly diagnosed atrial fibrillation that has not been previously diagnosed. Type 2, paroxysmal AF that terminates spontaneously within 7 days or with intervention. Type 3, persistent AF that does not terminate on its own. Many intervention studies have used 7 days as the cutoff point for persistent AF, and long-standing persistent AF is arbitrarily defined as uninterrupted AF for at least 12 months, but in which rhythm control is still an option in selected patients, distinguishing it from permanent atrial fibrillation. Type 4, permanent AF, in which no further attempts to restore sinus rhythm are planned, after a joint decision by the patient and physician. The European Heart Rhythm Association (MEHRA) also presents a classification of atrial fibrillation, which includes asymptomatic and symptomatic forms of AF, which include, first, asymptomatic C. Atrial fibrillation does not cause any symptoms. Second form, a mild form in which normal physical activity does not cause symptoms. Third, severe form, normal daily physical activity is limited. And fourth, disability. When normal daily physical activity is impossible, symptoms occur even at rest. Paroxysms of atrial fibrillation can also be divided by frequency. Infrequent paroxysms up to 1 episode per year, such as occasional, alcohol, or stress-induced, may not require aggressive treatment if asymptomatic and risk of stroke is low. Moderate frequency, several episodes per year, such as 2 to 6 times per year, may require intermittent use of antiarrhythmic drugs or lifestyle changes. Frequent paroxysms, monthly or weekly episodes, such as 1 to 4 times per month, often require daily use of antiarrhythmic drugs or ablation, and very frequent, such as several times per week or almost daily episodes. Adverse events associated with AF. Patients with AF also have high rates of hospitalization and complications from comorbidities. The most common non-fatal outcome in patients with AF is heart failure, occurring in about half of patients over time. The next most common adverse events of AF are ischemic stroke, coronary artery disease, and other thromboembolic events. The latter usually refers to arterial thromboembolic events, although venous thromboembolism has also been associated with AF. Patients with AF also have an increased risk of cognitive impairment and dementia. Atrial fibrillation is also associated with increased mortality. Atrial flutter, which has similar risk factors and complications, should also be considered. Initiation of oral anticoagulants. Atrial fibrillation is a major risk factor for thromboembolism, whether it is paroxysmal or persistent. Oral anticoagulants are recommended for those with a CHA2-DS2 vascular score of 2 or more and should be considered for those with a CHA2-DS2 vascular score of 1, following a patient-centered and collaborative care approach. Healthcare providers should take care to assess other risk factors for thromboembolism: chronic renal failure, atrial enlargement, hyperlipidemia, smoking, obesity, elevated natriuretic peptides, cystatin C, and interleukin 6, elevated troponin, and ethnicity, Black, Hispanic, Asian, which may also indicate the need for oral anticoagulants. However, when using oral anticoagulants, the following should be considered: Factor Xa inhibitors, rivaroxaban, apixaban, and edoxaban, as well as the direct thrombin inhibitor dabigatran, are not recommended in moderate to severe mitral stenosis, as they do not provide an antithrombotic effect due to atrial congestion. In this case, warfarin is the drug of choice. Their use is also controversial in rheumatic mitral valve disease and significant valve calcification. As you know, they are not used in mechanical valves. Antiplatelet drugs alone, aspirin or aspirin in combination with clopidogrel, are not recommended for stroke prevention in AF. The next thing to consider is invasive methods: percutaneous or surgical occlusion of the left atrial appendage, methods under development for thromboembolism prevention in selected patients. Advantages: eliminates the need for long-term anticoagulation, reduces the risk of stroke compared with warfarin, suitable for patients with a high risk of bleeding. egg with previous gastrointestinal bleeding, the elderly, frequent falls. Disadvantages: invasive procedure. There are differences and indications for each method. Percutaneous occlusion of the left atrial appendage is minimally invasive. Catheter. The success rate of closure of the left atrial appendage is up to 95 to 98%. Device-related thrombus, 3 to 5%. Risk of pericardial effusion, vascular injury. Requires short-term anticoagulation, antiplatelet therapy after the procedure, e.g., 45 days of warfarin plus aspirin, then dual antiplatelet therapy of aspirin plus clopidogrel for 6 months, then long-term, often aspirin alone. Not 100% effective, small residual stroke risk of 2 to 3% per year. Best suited for patients with AF with contraindications to long-term anticoagulation, but with high risk of stroke. Regarding the surgical technique, surgical occlusion of the left atrial appendage requires sternotomy, thoracotomy. The success rate of left atrial appendage closure is 90–95%. The thrombus associated with the surgical procedure is rare if completely removed, so anticoagulation after surgery is often not required. Short-term anticoagulation may be recommended to prevent thrombus formation during endothelialization of the surgical site, usually for 3 to 6 weeks after surgery. The best candidates for surgical left atrial occlusion are patients with AF who are already undergoing cardiac surgery. Rhythm control is therapy aimed at restoring and maintaining sinus rhythm. These treatments include cardioversion, antiarrhythmic drugs, percutaneous catheter ablation, endoscopic and hybrid ablation, and open surgical approaches. Treatment approaches aim to reduce symptoms by controlling heart rate and rhythm. As part of a comprehensive, patient-centered approach to care, rhythm control should be considered in all eligible patients with AF, with a clear discussion of the benefits and risks. Beta blockers, diltiazem, verapamil, or digoxin are recommended as first-line agents in patients with AF and left ventricular ejection fraction greater than 40% to control heart rate and reduce symptoms. In patients with AF and left ventricular ejection fraction less than 40%, beta blockers and/or digoxin are recommended to control heart rate and reduce symptoms. In acute settings, clinicians should always evaluate and treat underlying causes of AF prior to or concurrent with acute rate and/or rhythm control. These include treatment of sepsis, reversal of fluid overload, or treatment of cardiogenic shock. The choice of agent will depend on patient characteristics, the presence of heart failure, and the hemodynamic profile. In general, for acute heart rate control, beta blockers for all and diltiazem, verapamil for ejection fraction greater than 40% are preferred over digoxin because of their more rapid onset of action and dose-related effects. More selective beta-1 receptor blockers have a better efficacy and safety profile than non-selective beta blockers. Combination therapy with digoxin may be required in acute situations. Combinations of beta blockers with diltiazem or verapamil should be avoided except in situations requiring close monitoring. In selected patients with severely impaired left ventricular ejection fraction, intravenous amiodarone, landiolol, or digoxin may be used. Pharmacological control of heart rate can be achieved with beta blockers, diltiazem, verapamil, digoxin, or combination therapy. Intravenous, metoprolol tartrate, 5 mg bolus over 2 minutes, may be repeated every 5 minutes up to a maximum cumulative dose of 15 mg. Other beta blockers: oral metoprolol succinate, nebivolol, bisoprolol, carvedilol, and intravenous, esmolol, landolol. Non-selective beta blockers should be avoided in asthma. Contraindicated in acute heart failure and a history of severe bronchospasm. Non-dihydropyridine calcium channel antagonists, verapamil, diltiazem, both oral and intravenous forms, contraindicated in left ventricular ejection fraction less than 40%. Adjust doses in liver and kidney disease. Non-dihydropyridine antagonists are also contraindicated in atrial fibrillation, flutter with Wolff-Parkinson-White syndrome, may increase ventricular rate due to preferential conduction through accessory pathways. Glycosides. Digoxin alone is moderately effective in controlling ventricular rate at rest, but is generally ineffective with exercise and other states of high adrenergic tone, and is therefore not recommended as monotherapy for most patients. In combination with carvedilol, digitalis improves ventricular rate control and left ventricular function. High plasma levels are associated with adverse events. Check renal function before initiating digoxin and adjust the dose in patients with CKD. Amiodarone can control heart rate in AF, but V blockers and calcium channel blockers are preferred. Because of its broad profile of adverse extracardiac effects, amiodarone is reserved as a last resort when heart rate cannot be controlled, even with maximally tolerated combination therapy, or in patients who are not candidates for atrioventricular node ablation and pacing. Best reserved for selected cases, severe heart failure, intolerance to other drugs. Chronic use should be minimized due to risks of toxicity. Amiodarone is contraindicated in iodine sensitivity. Serious potential adverse effects, including pulmonary, ophthalmological, hepatic, and thyroid. Concomitant use of amiodarone and digoxin requires careful monitoring due to a significant pharmacokinetic interaction that increases the risk of digoxin toxicity. Other antiarrhythmic drugs with relatively pure sodium or potassium channel blocking properties, such as flecainide, ibutilide, and dofetilide, are generally not effective rate control agents during AF. Consider multiple drug interactions. What is the target heart rate during rate control? There is a consensus that tachycardias with higher heart rates and longer duration may lead to cardiomyopathy, CMP. However, the exact heart rate level that can cause TCMP is not well defined. Deterioration of left ventricular function can be caused by pacing rates greater than 240 beats minute and 450 beats minute in dog and rabbit models, respectively. These pacing rates are approximately twice the normal heart rate of dogs and rabbits. In our TCMP cohort, most patients had heart rates greater than 110-120 beats per minute. Other clinical trials have also reported that patients with TCMP had a similar heart rate range. In this context, a heart rate of 110-120 beats per minute, which is about twice the normal human heart rate, can be considered the threshold for tachycardiomyopathy. Until then, a resting heart rate of up to 80 beats per minute and up to 110 beats per minute during moderate exercise is recommended. A gentle control of 110 beats per minute may be the initial approach, unless there are persistent symptoms or suspicion of tachycardia-induced cardiomyopathy, in which case more stringent targets are indicated. A study of rate control versus electrical cardioversion in patients with new-onset symptomatic AF without hemodynamic compromise showed that a watchful waiting approach to spontaneous conversion within 48 hours of AF symptom onset was non-inferior to immediate cardioversion when followed for 4 weeks. Numerous studies have shown that rhythm control strategies have a positive impact on quality of life after sinus rhythm. An attempt to restore sinus rhythm is a reasonable first step. In patients with symptoms, consideration should be given to patient factors that favor an attempt at rhythm control, including suspicion of tachycardiomyopathy, a short history of AF, a non-dilated left atrium or patient preference, preserved left atrial size, better results if left atrial diameter is less than 50-55 mm. Significant left atrial enlargement reduces success rates. Implementation of the rhythm control strategy for 1 year compared with usual care significantly reduced the risk of cardiovascular death, stroke, or hospitalization for heart failure or acute coronary syndrome. Any rhythm control procedure has an inherent risk of thromboembolism. Patients undergoing cardioversion require at least 3 weeks of therapeutic anticoagulation, adherence with direct oral anticoagulants, or INR, greater than 2 if vitamin K antagonist, before the electrical or pharmacologic procedure. In acute situations or when early cardioversion is needed, transesophageal echocardiography, TEE, can be performed to rule out cardiac thrombus before cardioversion. If thrombus is detected, therapeutic anticoagulation should be instituted for at least 4 weeks, followed by repeat TE to ensure thrombus resolution. When the defined duration of AF is less than 48 hours, cardioversion is usually considered without the need for prior CBC or TEE to rule out thrombus. However, The definite onset of AF is often unknown, and observational data suggest that the risk of stroke, thromboembolic events is lowest over a much shorter period of time. This task force reached a consensus that safety should be the first priority. Cardioversion is not recommended if the duration of AF is greater than 24 hours, unless the patient has already received at least 3 weeks of therapeutic anticoagulation or transesophageal echocardiography has been performed to exclude intracardiac thrombus. Most patients should continue oral anticoagulants for at least 4 weeks after cardioversion. Only for those who have no risk factors for thromboembolism and sinus rhythm is restored within 24 hours of AF onset is oral anticoagulants after cardioversion unnecessary. In the presence of any risk factors for thromboembolism, long-term oral anticoagulants should be administered regardless of rhythm outcome. Electrical cardioversion. For biphasic cardioversion, an initial energy of 1.5 to 2 joules per kilogram, 100 to 200 joules of energy, can be used safely, routinely, and acutely with sedation with intravenous midazolam, propofol, or etomidate. In preparation for cardioversion, electrical or pharmacologic, certain medications may need to be stopped or adjusted to reduce risks. Key medications to consider include high digoxin levels increase the risk of post-shock ventricular arrhythmias. Check digoxin levels if toxicity is suspected. Digoxin should be stopped at least 24 to 48 hours before cardioversion, preferably 48 hours, if digoxin toxicity is suspected. Drugs that prolong the QT interval, risk of torsades de Pointes, macrolides, azithromycin, antipsychotics, haloperidol, methadone, some antiemetics, ondansetron. Assess the QT interval. Consider alternatives if possible. Beta blockers and calcium channel blockers, if pharmacologic cardioversion is planned. Avoid using AV nodal blockers, e.g. adenosine, verapamil, diltiazem, beta blockers, concomitantly with other rhythm control drugs. Risk of severe bradycardia or hypotension. Patients should fast for 6 to 8 hours before sedation if electrical cardioversion is performed under general anesthesia. Blood pressure monitoring and oximetry should be used routinely. Intravenous atropine or isoproterenol or temporary transcutaneous pacing should be available in case of post-cardioversion bradycardia. Immediate administration of vernaculant or pretreatment for 3 or 4 days with flecainide, ibutylide, propafenone, or amiodarone increases the rate of successful cardioversion and may improve long-term maintenance of sinus rhythm by preventing early recurrence of AF. A meta-analysis showed that pre-treatment with amiodarone 200-800 mg per day for 1 to 6 weeks before cardioversion and subsequent treatment with 200 mg per day significantly improves restoration and maintenance of sinus rhythm after cardioversion of AF. In some cases of persistent AF, there is no clear relationship between the arrhythmia and symptoms. In these cases, restoration of sinus rhythm by electrocardioversion may serve as confirmation of the influence of the arrhythmia on the symptoms and/or on the symptoms and signs of heart failure. Pharmacological cardioversion to sinus rhythm is an elective procedure in hemodynamically stable patients. It is less effective than electrical cardioversion in restoring sinus rhythm, with time to cardioversion being a significant determinant of success. The choice of a specific drug is based on the type and severity of underlying cardiac disease. A meta-analysis showed that intravenous vernaculant and flecainide have the highest conversion rates within 4 hours, possibly allowing patient discharge from the emergency department and shortening hospital stay. Of the Class C antiarrhythmic drugs, intravenous and oral flecainide are superior to propafenone in converting within 12 hours, while amiodarone has a delayed efficacy over 24 hours. It is important to follow the dilution protocol during amiodarone infusion because of the risk of adverse effects such as phlebitis and hypotension. The average daily dose of amiodarone is 1200 mg, providing sufficient antiarrhythmic effect. Pharmacological cardioversion does not require fasting, sedation, or anesthesia. Anticoagulation should be initiated or continued according to formal reassessment of thromboembolic risk. A single oral dose of flecainide, 200-300 mg, or propafenone, 450-600 mg, pill in the pocket, is effective in symptomatic patients with infrequent and recent onset paroxysmal AF. Safe use of this strategy requires patient screening for sinus node dysfunction, atrioventricular conduction defects, or Brugada syndrome, as well as prior in-hospital validation of its efficacy and safety. An atrioventricular node blocking agent should be given to patients being treated with Class C antiarrhythmic drugs to avoid 1-1 conduction if the rhythm degenerates into atrial flutter. The goals of long-term rhythm control are to maintain sinus rhythm, improve quality of life, slow the progression of AF, and potentially reduce morbidity associated with episodes of AF. Antiarrhythmic drugs also have a role in long-term rhythm control in patients with AF who are considered ineligible or unwilling to undergo catheter or surgical ablation. All antiarrhythmic drugs can cause serious cardiac proarrhythmia, negative inotropism, hypotension, and extracardiac side effects, organ toxicity, mainly amiodarone. Drug safety, not efficacy, should guide drug choice. The risk of proarrhythmia is increased in patients with structural heart disease. Recommendations for antiarrhythmic drugs for long-term maintenance of sinus rhythm. Amiodarone is recommended for patients requiring long-term antiarrhythmic maintenance therapy to prevent recurrence and progression of atrial fibrillation, taking into account extracardiac toxicity and monitoring that may be used in cases of decreased systolic contractile function. Dronedarone is recommended for patients with atrial fibrillation who require long-term rhythm control, who have preserved or mildly decreased systolic contractile function, coronary artery disease, or valvular disease to prevent recurrence and progression of atrial fibrillation. Dronedarone is structurally similar to amiodarone but lacks the iodine groups of amiodarone. Although the lack of iodine groups reduces the incidence of adverse events, dronedarone is less effective at controlling rhythm than amiodarone. Dronedarone has been found to be associated with increased mortality in patients with permanent AF. The randomized, double-blind, phase 3 permanent atrial fibrillation. Using dronedarone on top of standard therapy, PALAS trial was stopped after a preliminary review found that dronedarone was associated with a twofold increase in the risk of death. There was also a twofold increase in two other endpoints, stroke and hospitalization for heart failure compared with placebo. The FDA recommends that healthcare professionals not prescribe dronedarone to patients with permanent AF. A separate study by Connolly et al. Also found that dronedarone increased the incidence of heart failure, stroke, and cardiovascular death in patients with permanent AF who are at risk of major vascular events. The authors of that study suggested that dronedarone should not be prescribed to this group of patients. Flecainide or propafenone is recommended for patients with atrial fibrillation who require long-term rhythm control to prevent atrial fibrillation and its progression, except for patients with impaired left ventricular systolic function, severe left ventricular hypertrophy, or ischemic heart disease. Recommendation: First Class A. Sotalol is effective but, like other Class 3 drugs, requires careful monitoring of the QT interval and serum electrolytes. Sotalol is associated with a risk of QT prolongation and tossades de pointes. The proarrhythmic effect of sotalol is increased in patients with congestive heart failure, unlike dofetilide and amiodarone, so it is generally contraindicated in these patients or in patients with a prolonged QT interval. Hypokalemia should be corrected and monitored before administering sotalol, as it may also prolong the QT interval. Sotalol may be used in patients with coronary artery disease. Class 3 drugs sotalol, amiodarone, also have some beta-blocking effect and should be used with caution in patients with a history of bradycardia. Because of the possible proarrhythmic side effects of antiarrhythmic drugs, such patients should be monitored for at least 24 hours, in most cases requiring hospitalization. Patients starting sotalol usually require inpatient monitoring, risk of torsades de pointe, although patients without heart disease, with a QT interval of less than 450 milliseconds and normal electrolytes should be started on an outpatient basis. At least 24 hours of monitoring after cardioversion with amiodarone. Extend to 48 hours if risk is high. For flecainide, propafenone more than 24 hours. For ibutilide more than 4 hours after infusion, high risk of ventricular tachycardia. For dofetilide sotalol more than 48 hours. QT monitoring start in hospital. Ablation prevents AF recurrence and improves quality of life in symptomatic paroxysmal or persistent AF when the patient is intolerant of or unresponsive to at least one antiarrhythmic drug. Multiple studies have provided evidence to support catheter ablation as a first-line approach to rhythm control in patients with paroxysmal AF with similar risk of adverse effects compared with initial antiarrhythmic drug treatment. Catheter ablation may also have a role in patients with symptoms caused by long pauses after AF termination, where non-randomized data have shown improvement in symptoms and avoidance of pacemaker implantation. Randomized trials have shown that catheter ablation of AF in patients with reduced systolic contractile function significantly reduces arrhythmia recurrence and increases ejection fraction, with improved clinical outcomes and mortality also seen in selected patients. Management of arrhythmia recurrence after ablation is an informed, shared decision-making process guided by available symptom control options. Atrioventricular node, ablation, and pacemaker implantation. Ablate and pace can slow and regularize the heart rate in patients with AF. It is a highly effective treatment for patients with atrial fibrillation and high ventricular rates refractory to other treatments, particularly in the elderly or those with severe comorbidities. The procedure has a low complication rate and a low risk of long-term mortality. The pacemaker should be implanted several weeks before atrioventricular node ablation, with the initial pacing rate after ablation set at 70 to 90 per minute. This strategy does not worsen left ventricular function and may even improve left ventricular vibration fraction in selected patients. The evidence base typically includes elderly patients. For younger patients, ablation and pacing should be considered only if the heart rate remains uncontrolled, despite consideration of other pharmacologic and non-pharmacologic treatment options. The choice of pacing therapy, right ventricular or biventricular pacing, depends on patient characteristics, presence of heart failure, and left ventricular ejection fraction. In patients with severe symptoms and permanent AF, who have had at least one hospitalization for heart failure, atrioventricular node ablation in combination with CRT should be considered. Rhythm control strategies in patients with AF. For patients with acute or worsening hemodynamic instability presumed to be due to AF, prompt electrical cardioversion is recommended. For other patients, watchful waiting should be considered as an alternative to immediate cardioversion. Short-term antiarrhythmic drug treatment, 2 to 3 months, after ablation reduces early AF recurrence but does not affect late recurrence or clinical outcomes at 1 year. Repeat ablation should be offered to patients with AF recurrence if symptomatic improvement has been demonstrated after the first ablation. Ablation techniques may be successful in patients with congenital heart disease, but the recurrence rate of AF may be high. The presence of a left atrial thrombus is a contraindication to catheter ablation of AF due to the risk of thrombus dislodgement leading to ischemic stroke. Patients scheduled for catheter ablation of AF with an increased risk of thromboembolism should take oral anticoagulants for at least 3 full weeks prior to the procedure. In addition, several subgroups of patients with AF have an increased risk of ischemic stroke and intracardiac thrombus even when treated with adequate anticoagulation, including patients with cardiac amyloidosis, rheumatic heart disease, and hypertrophic cardiomyopathy. Cardiac imaging before catheter ablation should be considered in these high-risk patient groups, regardless of prior effective oral anticoagulation. Observational studies suggest that patients with a low thromboembolic risk profile can be treated without left atrial appendage imaging, but no randomized controlled trials have been performed. In patients who have been prescribed anticoagulant therapy before the ablation procedure, it is recommended to avoid interruption of oral anticoagulants. Heparin administration during AF ablation is common practice. After ablation, oral anticoagulants should be continued according to the dosing regimen once hemostasis is achieved. All patients should continue direct oral anticoagulants for at least 2 months after the AF ablation procedure, regardless of the estimated thromboembolic risk. Performing surgical ablation of AF, primarily in patients requiring mitral valve surgery, is not associated with increased morbidity or mortality. Observational data, including large registries, have supported the potential value of surgical ablation of AF, but further studies are needed to evaluate which patients should be selected and whether this approach helps prevent stroke, thromboembolism, and death. After any AF ablation, recurrent arrhythmias may manifest as AF, but also as atrial tachycardia. Although the treating physician may perceive atrial tachycardia as a step in the right direction, this view is often not shared by the patient because atrial tachycardia can be as or more symptomatic than the original AF. Traditionally, early recurrence of arrhythmia after ablation, whether atrial tachycardia, AF, or flutter, is considered potentially transient. Unstable patients with AF include those with hemodynamic instability due to arrhythmia or acute cardiac events, and critically ill patients who develop AF, sepsis, trauma, surgery, and especially cancer surgery. Conditions such as sepsis, adrenergic overstimulation, and electrolyte disturbances contribute to the onset and recurrence of AF in these patients. Spontaneous restoration of sinus rhythm has been reported in 83% within the first 48 hours after appropriate treatment of the underlying cause. Emergency electrical cardioversion is still considered the first-line treatment if sinus rhythm is considered beneficial, despite the limitation of a high rate of immediate recurrence. Amiodarone is a second-line option due to its delayed activity. However, it may be an appropriate alternative in the acute setting. In a multi-center cohort study conducted in the United Kingdom and the United States, amiodarone and beta blockers were equally effective in controlling heart rate in intensive care patients and were superior to digoxin and calcium channel blockers. The ultra-short-acting and highly selective beta blocker landiolol can safely control rapid AF in patients with low ejection fraction and acute decompensated heart failure, with limited effect on myocardial contractility or blood pressure. 10 to 15% of patients with AF undergo percutaneous intervention for coronary artery disease. In acute stroke or intracranial hemorrhage, treatment should be coordinated by a specialist neurology team in accordance with relevant guidelines. Resumption of anticoagulation in ischemic stroke or intracranial hemorrhage is a decision that must be made on an individual case-by-case basis, taking into account the severity of the hemorrhage or infarction, the systemic risk of bleeding, and the risk of thromboembolism in the absence of anticoagulation. Timing of anticoagulation. Early anticoagulation up to 14 days. Considered for low-risk hemorrhagic transformation, e.g. small infarction without risk of major bleeding. Delayed anticoagulation. After 14 days, preferred for large infarctions, uncontrolled hypertension, or high risk of bleeding, e.g. 2 to 4 weeks after stroke. Recent trials. Some evidence. EGI-ELAN study supports early anticoagulation for 48 hours for minor strokes, 6 to 7 days for moderate strokes. Re-challenge EG for recurrent stroke prevention. Long-term anticoagulation, egapixaban, rivaroxaban, is usually continued indefinitely unless contraindicated. In intracerebral hemorrhage, the optimal time to start anticoagulation for the different indications is difficult to determine. Hemorrhagic stroke intracerebral hemorrhage. Timing of resumption of anticoagulation. High thrombotic risk egg mechanical heart valves may be restarted after 4-8 weeks, balancing the risk of bleeding and thromboembolism. Atrial fibrillation is often delayed by 4-8 weeks depending on the location of the hemorrhage, lobar or deep, and modifiable risk factors such as hypertension control. In a retrospective study from South Korea, it was shown that the resumption of anticoagulation after 6 to 8 weeks after intracerebral hemorrhage reduces the risk of mortality from any cause and the risk of severe thrombotic and hemorrhagic events. In one study, the resumption of therapeutic anticoagulation less than 2 weeks after intracerebral hemorrhage in people with a mechanical heart valve was associated with an increase in hemorrhagic complications. Key considerations for both stroke types. Imaging. Repeat neuroimaging, CT-MRI, to assess stability before resuming anticoagulation. Bleeding risk scores. Has bled, CHA2, DS2 vascular, help guide decisions. Alternative strategies. Left atrial appendage occlusion for AF if anticoagulation is contraindicated. Antiplatelet agents, e.g. clopidogrel, as a temporizing measure in high-risk scenarios. Patient and family involvement in decision-making is important, and people should be aware that delayed anticoagulation does not completely prevent bleeding, and early anticoagulation does not completely prevent stroke. Resumption of anticoagulants after surgery depends on several factors, including the type of surgery, the patient's bleeding risk, and thromboembolic risk. Here are some general guidelines. Surgeries with a low risk of bleeding, e.g., minor dermatologic, dental, cataract surgery, can often be resumed within 24 hours of surgery. Surgeries with a high risk of bleeding, e.g., major abdominal, brain, spine surgery, usually delayed for 48 to 72 hours or longer. Patients with a very high risk of thrombosis, egg, mechanical heart valves, recent venous thromboembolism, may require switching to heparin or low molecular weight heparin until oral anticoagulants are safe. In triggered AF, triggered induced AF is defined as new AF in direct association with a precipitating and potentially reversible factor, also known as secondary AF. The most common precipitating factor that shows a tendency to AF is acute sepsis, in which the prevalence of AF is 9 to 20% and is associated with a worse prognosis. Long-term data suggest that sepsis-induced AF recurs after discharge in 1/3 to 1/2 of patients. Triggers may be any of the following: acute conditions, infections, bacterial and viral, pericarditis, myocarditis, emergency conditions, burns, severe trauma, shock, excessive alcohol consumption, drug use including methamphetamines, cocaine, opiates, and cannabis, acute interventions, procedures and surgery, endocrine disorders, immune-mediated diseases, obesity, chronic obstructive airway disease, obstructive sleep apnea, cancer. Treatment should be directed primarily at the underlying disease and antiarrhythmic therapy, rhythm, or heart rate control. And anticoagulant therapy should be initiated or delayed based on the individual patient's current disease status, taking into account the benefits and risks. Perioperative AF describes the onset of arrhythmia during an ongoing procedure. Postoperative AF, defined as new onset AF in the immediate postoperative period, is a common complication with clinical impact, occurring in 30% to 50% of patients undergoing cardiac surgery and 5% to 30% of patients undergoing non-cardiac surgery. Although episodes of postoperative AF may resolve spontaneously, postoperative AF is associated with a 5-fold increase in AF recurrence over the next 5 years and is a risk factor for stroke, myocardial infarction, heart failure, and death. Other adverse events associated with postoperative AF include hemodynamic instability, prolonged hospital stay, infection, renal complications, bleeding, increased in-hospital mortality, and higher healthcare costs. In a meta-analysis, oral or intravenous amiodarone and beta blockers were equally effective in reducing postoperative AF, but their combination was better than beta blockers alone. Atrial fibrillation is one of the most common arrhythmias during pregnancy, its prevalence increasing with older maternal age and lifestyle changes, and because more women with congenital heart disease survive into childbearing years. Rapid atrioventricular conduction of AF may have serious hemodynamic consequences for the mother and fetus. AF during pregnancy is associated with an increased risk of death. A multidisciplinary approach involving gynecologists, neonatologists, anesthesiologists, and cardiologists with expertise in obstetrics and gynecology is needed to prevent maternal and fetal complications. The preferred agents for anticoagulation of AF during pregnancy are unfractionated or low molecular weight heparins, which do not cross the placenta. Vitamin K antagonists should be avoided in the first trimester, risk of miscarriage, teratogenicity, and from 36 weeks, risk of fetal intracranial hemorrhage in early unexpected birth. Direct oral anticoagulants are not recommended during pregnancy due to safety concerns. However, accidental exposure during pregnancy should not lead to a recommendation for termination of pregnancy. Vaginal delivery should be encouraged in most women, but is contraindicated during vitamin K antagonist treatment due to the risk of fetal intracranial hemorrhage. Intravenous beta-1 selective receptor blockers are recommended as first choice for acute heart rate control in AF. This does not include atenolol, which may cause intrauterine growth restriction. If beta blockers are ineffective, digoxin and verapamil may be considered for rate control. Verapamil should be avoided in the first trimester. Rhythm control is the preferred strategy during pregnancy. Electrical cardioversion is recommended in the presence of hemodynamic instability. Electrical cardioversion can be performed safely without compromising fetal blood flow, and the subsequent risk of fetal arrhythmias or preterm labor is low. Fetal heart rate should be closely monitored during and after cardioversion, which should generally be preceded by anticoagulation. In hemodynamically stable women without structural heart disease, intravenous ibutilide or flecainide may be considered for AF termination, but experience is limited. Catheter ablation is generally avoided during pregnancy, but is technically feasible without radiation in refractory symptomatic cases with a minimal no fluoroscopic approach. Endocrine dysfunction is strongly associated with AF, both as a direct effect of endocrine hormones and as a consequence of treatment for endocrine disorders. Clinical and subclinical hyperthyroidism, as well as subclinical hypothyroidism, are associated with an increased risk of AF. Patients with new onset or recurrent AF should have thyroid-stimulating hormone levels checked. Amiodarone causes thyroid dysfunction in 15 to 20% of treated patients, leading to both hypo and hyperthyroidism, requiring referral to an endocrinologist. Hypercalcemia can also cause arrhythmias, but the role of primary hyperparathyroidism in causing AF is poorly understood. Surgical parathyroidectomy has been found to reduce both supraventricular and ventricular extrasystoles. Hypercalcemia can also cause arrhythmias, but the role of primary hyperparathyroidism in causing AF is poorly understood. Rhythm control approaches in AF can be challenging in patients with inherited cardiomyopathies and primary arrhythmia syndromes. For example, many drugs have a higher risk of adverse effects or may be contraindicated, e.g. amiodarone and sotalol in congenital long QT syndrome, and class Y antiarrhythmic drugs in Brugada syndrome. Because of long-term adverse effects, chronic use of amiodarone is problematic in these typically young patients. In patients with an implantable cardioverter defibrillator, AF is a common cause of inappropriate shocks. Programming a single VF zone at a high rate of 210 and/or 220 beats per minute with a long detection time is safe and is offered to patients without documented slow monomorphic ventricular tachycardia. Implantation of an atrial lead may be considered in cases of significant bradycardia during beta blocker therapy. Patients with Wolff-Parkinson-White syndrome and AF are at risk of rapid ventricular rate due to rapid conduction of atrial electrical activity to the ventricles via the accessory pathway, which may lead to ventricular fibrillation and sudden death. Immediate electrical cardioversion is necessary for patients with hemodynamic compromise and pre-excited AF, and atrioventricular node modulating drugs should be avoided. Pharmacological cardioversion with ibutilide or flecainide may be attempted, while propafenone should be used with caution due to effects on the atrioventricular node. Amiodarone should be avoided in pre-excited AF due to its delayed action. Now let's consider atrial flutter. Rate control can be difficult to achieve in atrial flutter despite combination therapy. Rhythm control is often the first-line approach, with small randomized trials showing cavo-tricuspid isthmus ablation to be superior to antiarrhythmic drugs. Recurrence of atrial flutter is rare once bidirectional block is achieved and confirmed in typical CTI-dependent atrial flutter. Given its high success rate and low complication rate, radiofrequency ablation is superior to medical therapy. The need for cardioversion may be acute if AF is the cause of hypotension, heart failure, or angina. The success rate of electrical cardioversion is greater than 95%. Atrial flutter generally requires less energy to convert than AF. As little as 50 joules of energy may be required. Anticoagulation is the same as for AF. As with patients with AF, the decision on the need for post-conversion anticoagulation is made after assessing the individual risks of thromboembolism and bleeding in each patient. The main difference between atrial fibrillation and atrial flutter is that most cases of atrial flutter can be treated with radiofrequency ablation, drugs that can be used for pharmacological cardioversion of atrial flutter. Dofetilide is effective in 70 to 80% of patients with atrial flutter. This drug should be given in a hospital setting. Ibutylide is also effective, converting new-onset atrial flutter to sinus rhythm in 63% of patients with a single infusion. However, these drugs are not available in all countries. Due to the risk of QT prolongation and torsade de pointes, it should be given in a controlled setting. Continuous ECG monitoring is indicated for at least 4 hours after the infusion. Ibutylide should not be used in patients with severe chronic heart failure, hypokalemia, or pre-existing prolonged QT interval. Pharmacological cardioversion is generally less effective in atrial flutter than in AF. In all available studies, catheter ablation is superior to rate and rhythm control strategies with antiarrhythmic drugs. AF ablation is now a class indication and first-line therapy for selected patients. For elderly patients, age alone is not a reason to refuse, but frailty, other heart diseases, EDGE, severe heart failure, or high surgical risk may affect the possibility of ablation. Elderly patients, EG over 80 years, may also undergo ablation if they are in good health and the benefits outweigh the risks. Success rates may vary with age due to the characteristics of the heart tissue. Risks, bleeding, stroke, anesthesia complications are assessed individually. If ablation is too risky, alternative options, drugs, pacemakers, may be considered. In conclusion, because AF promotes pathological atrial and ventricular remodeling, restoration of sinus rhythm can slow or in some cases reverse atrial dilation and left ventricular dysfunction. For these reasons, most clinicians initially focus on restoration and maintenance of sinus rhythm in patients with newly diagnosed AF and choose a rate control strategy only if rhythm control fails. The clinical decision to use a rhythm or rate control strategy requires a comprehensive consideration of several factors, including the severity of symptoms, the likelihood of successful cardioversion, the presence of comorbidities, and the candidacy for AF ablation. I hope today's topic will strengthen your knowledge. Thank you for your attention.